What question you got?
Oh, we were asking about aspirin falling into that category.
Yeah, aspirin is not as strong as heparin, and so it helps, but it doesn't. It's just not as potent. Yes.
Anticoagulant prevents the blood from clotting, thrombolytic, break up the clot.
Exactly, a very important point. If a patient has a blood clot, you can give all the heparin in the world and it will not break up the clot. It will just keep the clot from getting bigger and keep more clots from forming. But a thrombolytic literally goes to the clot and busts it up. So I would be familiar with some of these thrombolytic agents: streptokinase, urokinase, adaplase, retaplase. What do you notice about these thrombolytics? ACE is on the end. And there's a lot of contraindications to thrombolytics, so the patient's history has to be looked at. If their blood pressure's really high, the blood pressure has to be brought back down before they can be started. If the blood pressure is really low, it has to be brought up some. But usually blood pressure's high. And what's the best treatment overall? Prevention, and moving prevents. Now, something else that I want you to think about is inferior vena cava filters may help to catch any embolism that are getting ready to go into the pulmonary circulation. And pulmonary embolectomy, actually going in and surgically removing the clot. Does anybody watch The Resident?
Yes.
It came on the week before last. I think they had a pulmonary embolism that had to be surgically removed. I love that show. I'm getting into it. I have to tape it though.
Is there an oxygen therapy protocol?
It is the same for any. You look at the pulse ox and the blood gas and base your oxygen therapy on the PaO2. And typically the PaO2 is going to be low because of the venous admixture. Okay, and then the last part of this chapter is pulmonary hypertension. Now, what I'm thinking about is having a test next week on pulmonary edema and pulmonary embolism and pulmonary hypertension. I think we can get at least 50 or 60 points on a test for these things. And then that way we'll, kind of keep in line with our testing. So let's plan on that. Not flail chest, pulmonary edema, pulmonary embolism, and pulmonary hypertension. So with pulmonary hypertension, where is the increased pressure? Huh? In the pulmonary vasculature. So the whole pulmonary vasculature is typically affected. Now, do you by chance remember? You probably don't. What is the normal pulmonary artery pressure? And this is a mean pressure. So typically the pulmonary artery pressure is, depending on what book you look at, about 20 to 30 over what units are these in? So let's figure out what the mean pulmonary artery pressure is. How are we going to do that?
5,
Okay, I'm going to take 20 plus 4 plus 4 and divide it by, and then I'm going to take 30 plus 12 plus 12 and divide it by, where did I get this formula from? One systolic plus 2 diastolic divided by 3 is the mean arterial pressure calculation. The pulmonary artery is an artery, so we can use this same formula to find the mean. So 20 plus 8 equals divided by 3, 9.3. And 18. So that's pretty close to 10 to 20. Y'all with me? So what is probably the most common cause of pulmonary hypertension? What causes the pulmonary vessels to constrict? Yes, but what about the COPD? The hypoxia. The pulmonary vessels are the only vessels that constrict when there's hypoxia. What do the systemic vessels do? They dilate. When your muscles need more oxygen or your tissues need more oxygen, the systemic vessels dilate. Okay, look at page 312. There are 5 groups of pulmonary hypertension. And I know your comp says to list these 5 groups, but I want you to just look at them. We've got idiopathic, heritable, which means inherited pulmonary hypertension. Certain drugs can cause it. Sickle cell anemia. Group 2 is left heart failure. Group 3 is lung disease or hypoxemia. Group 4 is thromboembolic pulmonary hypertension, and this is chronic embolisms. And 5 is unclear multifactorial mechanisms like polycythemia, sarcoidosis, tumors, and so forth. So we've got some different things that can cause the pulmonary vasculature to constrict. But one of the more common causes is in group 3, and that is chronic obstructive pulmonary disease because of hypoxia. Now look at 313, some of these general findings. Dyspnea, lightheadedness, hemoptysis, hoarseness, racing heartbeat, decreased appetite, swollen and tender liver, pitting edema. So as you are doing breathing treatments on patients, as patients come into the ER and you're assessing them, be on the lookout for things that could be wrong other than, you know, what you're treating, you know, what you're doing in the room. Now, what else is important? So which part of the heart is most affected by pulmonary hypertension? Huh?
Right?
The right side of the heart. Which ventricle has to pump into the pulmonary vasculature? The right. What is happening to the resistance that the ventricles have to pump against? It's increased. So we have increased afterload on a beat by beat basis. So we're going to have to figure out how to decrease the pulmonary hypertension or how to increase the vessel size. So some of the things that may be done is diuretics to help with some of the fluid going back to the right side of the heart. If there's a cause like polycythemia, or if there is some type of platelet coagulation, then having the patient on blood thinning meds may work. Increasing the right